treatment options for thoracic disc herniation. First of all, I'd like to start with a case. This is a 38-year-old male who presented with a 9-month history of tightness in his back with an elastic band sensation. He had progressive tightness in quadriceps and knees, numbness in both calves and toes. He felt off balance and he had no bowel or bladder symptoms. His tone was increased in his lower extremity, more on the right than the left. He had normal tone in his upper extremities. His bulk was normal and his power was 5 out of 5 in both upper and lower extremities. He had sustained clonus on the right side and 5 beats on the left side. His upper extremity reflexes were normal with a negative Hoffman, and he had a positive Babinski. His sensory exam, he had a sensory level T10 on the right side and T9 on the left side. He had decreased vibration sense in his lower extremities, more on the right than the left. And this is his MRI scan, which shows that at T6 and T7 he had a disc herniation. And a CT scan confirmed that it was extensively calcified and occupying most of the canal. So I'll get back to the case after speaking a little bit about thoracic disc herniations. So disc herniations are fairly common with a frequency of 40 to 50 per 100,000 people. However, thoracic disc herniations are much rarer with a frequency of 1 per 1 million people. Thoracic disc herniations are more common in adults between 30 and 50 years of age with equal distribution between the two genders. Surgical procedures in the thoracic spine make up to 0.15 to 4% of procedures of disc herniations. Surgery for thoracic disc herniations have poor reputation because of the technical difficulties and the risk of potential serious and hard to treat complications. The location of the disc in 75% occupies the region below T7 and T8 disc. The T11-12 disc is most vulnerable because of the greater mobility and posterior longitudinal ligament weakness at this level. Only around 4% of thoracic disc herniations are located above T3-4. The particularity of thoracic disc herniation is the frequency of calcification or even ossification of the disc. Usually they're diagnosed clinically and radiographically. Thoracic disc herniations manifest in back pain, radicular pain, or medullary neurological deficits, also known as myelopathy. Giant calcified discs cause myelopathy in 95% of cases. MRI is the gold standard in diagnosing thoracic disc herniation. CT scan is necessary and important to assess calcification of the disc. When do we operate on these patients? Decided usually upon when the patient has functional symptoms that do not respond to medical treatment and or when neurological symptoms appear or worsen. The presence of myelopathy signs on MRI, which are indicated by a hypointense T1 signal and intramedullary hyperintense T2 signal, even the absence of clinical neurological signs before these signs appear and become irreversible, is an indication for surgery in my practice and for my training. So for surgical treatment, there are some intraoperative prerequisites, such as having intraoperative monitoring. Now, there is no consensus about the usage of intraoperative monitoring in these cases. However, it is highly advisable to be used. Obviously, having some sort of microscope to better visualize the field. And there are multiple approaches for thoracic disc herniations based on the location of the disc. So there's the conventional posterolateral with pedicular transfacet and transfacet variation with sparing of the pedicle. There's the lateral, such as the costotransversectomy or extended lateral extracavitary. And there's the anterior, such as the transpleural thoracotomy, thoracoscopy, and mini thoracotomy with retroperitoneal variation. So these are just the approaches and the access that you get with each approach, starting with the laminectomy, transfacet, and all the way down to the transthoracic. So the posterior lateral approach is mostly indicated for soft lateral disc herniations. It consists in a posterior approach and a unilateral or bilateral arthrotomy, which is a fastectomy, which provides access to the disc space. The anterior side of the dura sheet can be separated from the hernia, which is easier by ligating the corresponding nerve root. The pedicle can be preserved or reamed as needed depending on the extent of the herniation, and fusion is performed in most cases with violation of the facet and pedicle. If the sheet cannot be
Good
separated
morning,
from the
everyone.
calcification, leaving the hernia's calcified shell on the dura mater to avoid dural fistula is advisable. So here, a demonstration showing the transfacet approach. By drilling the facet, your disc is immediately beneath that area, and that should be identified using fluoroscopy. Then we have the anterior transthoracic approaches, which give you a direct view of the central and or calcified hernias. Single lung ventilation is used usually to better mobilize the lung out of the way. You can also use an open
It's a
mini
great.
thoracotomy uh, to get around the challenges of thoracoscopy and the morbidity associated with thoracotomy. The retropleural approach is preferred to reduce the morbidity associated with the transpleural approach. So this is the retropleural approach. Obviously, you resect part of the rib and then go through and sweep the dura off the rib all the way down until you reach the rib head.
Dear
The rib
friends,
head is then resected, and then the burr is used to burr part of the pedicle um, below the disc as well as the body above and below to create a trough and then deliver the disc into that space without pushing on the dura. Fusion is usually required in posterior approaches. However, for anterior approaches, resection of the head of the rib and pedicle, as well as the posterior margin of the vertebral body adjacent to the disc, does not cause any significant instability and therefore does not require any fusion. Now, the long-standing myelopathy lesions have a worse prognosis with uh, uh, than the ones with short-lasting nerve root compression. Complications are high and usually are at 20 to 30% in cases. These can be lung-related complications that occur usually with the anterior approach, such as atelectasis, pneumopathy, and pleural effusions. And these are usually reversible but prolong the hospital stay. Their incidence is not altered significantly by the use of the thoracoscopic approach versus mini thoracotomy. Obviously, neurological complications, medullary in particular, permanent postoperative deterioration of the neurological conditions have been reported in all studies, no matter which approach is used, at a frequency of 2 to 5%. The most at risk patients are those with a giant calcified thoracic disc herniation who have neurological signs preoperatively. Intercostal neuralgia is also one of the things that can happen. At 5 years postoperatively, intercostal neuralgia has been found in 30% of patients undergoing thoracotomy versus only 6 to 15% after thoracoscopy. Dural tears are high and usually come at around 15 to 39% in cases. So coming back to our case, we did a thoracotomy, retropleural approach, and resected part of the body and pedicle and delivered the disc space into that area without any complication using intraoperative monitoring. And there is a clear postoperative CT showing the decompression without the need for fusion. Thank you.